welcome to Hopkins. This is the second day. It's the day of moving thought into action, very important, I think, for all of you. Also very important for us at the School of Public Health. Our footprint not only is Baltimore and U.S., but global, and we all know how much action is needed to solve the health and social needs of the world, as well as close to home. And working with stewards for this conference every year since the beginning is really a part of that. I think there's probably no confluence that is greater in both the health, public health, medical, and of course social services than technology and the need for integration. We've been talking about it a long time, but I actually think we're close. Certainly in the work that I've been doing, I started a new center at the Bloomberg School of Public Health. We call it the Center for Population Health IT, or Informatics, where we don't talk about it. We are linking more than we ever have in my 30-year history, social services data, medical data, public health data. As Daniel just said, it's not the technology. Sure, we have challenges in technology. It's a lot more than that. It's administrative, it's financial, it's legal, it's ethical, but we can do it. And I think obviously the terrible opioid epidemic has been a teachable moment, something that we've got to do something about. And I personally have never had more access to data than I have. The state of Maryland has opened all of their data to our team to try to do what we can. Coroner's data and corrections data and juvenile services and medical and public health. That hasn't happened in 30 years. So the lawyers got together and it can happen. Now, we here at Hopkins and you heavily from the state, of course, are very dependent on our colleagues from the federal government. Obviously, we are all very anxious. This is a sensitive time, a time when it's taken, this is where me not being the dean is important, to try to be tactful but direct. Obviously, there's a lot of concerns. But my concerns were assuaged to a significant extent when I saw the quality of the people on the panel today that we're about to hear from. I know it's challenging for representatives of the federal government to sort of be themselves and share their ideas and share what they would like to do, because also there is a party line. I think it's all important not to think about people as one side of the aisle, the other side of the aisle, and recent events have shown that we can come together. And I hope it's in that spirit of coming together that we can spend time today hearing from our federal colleagues. And again, the Washington-Baltimore 30 miles is sort of a close 30 miles, yet a far 30 miles. So in fact, sometimes the feds come up here when they want to get away from the DC Beltway. But yet we're close enough that they were able to drive together. But I hope that we can hear from the panel suggestions. You've got the best of the best from the states. You have private and public. We have something where the goal is efficiency. We have technology all dressed up with nowhere to go in some cases. The technology has been there for a while, but we haven't been able to use it. We have really smart, well-intentioned people. With the right leadership and some resources from the feds, I think we can achieve a lot over the next 3.5 years. So with that, trying to be positive and honest about both the opportunities and the challenges, of which they're both. I'm going to only introduce Wade Horn, who's the moderator, and he'll introduce the others. Dr. Wade Horn, and Wade started out as a clinical psychologist, so he gets it when it comes to services. He's currently the managing director at Deloitte, and he was the assistant secretary for children and families from HHS from 2001 to 2007. That's a long tenure. So he must be doing something right. And he will introduce the feds. And I would encourage, I know some of you are aware of stewards. I think all of you are aware of the needs out in the community and the focal point that information technology plays for meeting those needs. So thank you for coming up to Baltimore, and we look forward to really one of the more important sessions of the whole conference.
Well, thank you very much, Jonathan, for the nice introduction to this panel. It's a real treat to be here. I want to extend my thanks to my good friend Daniel for inviting us to be here today. I know Daniel and many of you have been laboring around these issues of interoperability for quite some time before it was popular to do so, and I think that one of the reasons why it has become so popular to talk about interoperability is because of the work of this symposium, the work of Daniel in particular, and the work of all of you here today. So I extend my thanks for the work that you've been doing. We have a terrific panel here today of some new leaders at HHS and some not so new leaders at HHS, but thought that it might be of interest for you to hear their perspective on the issues that you've been talking about over the last several days. I'm Wade Horn, as Jonathan introduced me, and I've been spending a little bit of time over the last 4 months or so at HHS, getting to know the new leadership, and so it's a real treat. And I will tell you, I had my fingers and toes crossed that this morning the secretary was not going to wake up and say, I need Nina Schaefer, Don Rucker, and Bruce Greenstein in my office at 8 o'clock this morning. So I turned off all their cell phones so they couldn't get that call. So I'm going to introduce just with title and name, because I'm going to do something a little bit different for the first question, and actually have them talk a little bit about themselves and introduce themselves to all of you, because some of them are not just new to government, or at least HHS, but are new to this symposium and this group. So first we have Nina Schaefer, who is a senior counselor to Secretary Tom Price. We have Don Rucker, who is the national coordinator in the Office of the National Coordinator, and Bruce Greenstein, who is the Chief Technology Officer at HHS. I knew I would. And then we have Chris Traver, who is the Senior Advisor. I'm doing this all from memory. You should be impressed. The Senior Advisor in Interoperability czar, I'll call you, at ACF. And so because this is a new leadership team, and some of you are new to government, some have been in government before, and some are a little bit more long-timers, I thought the first thing I might ask each of you to do is just say a little bit about yourself, introduce yourself a little bit, and then talk a little bit about what your professional interests are and what really motivated you to want to take time out of your very successful careers outside of government and come in government to take on these very important leadership roles. So Nina, I'll start with you.
Sure, well thank you. Are these on? Technology is not my thing. Surprising I'm here. Well, thank you so much for having me and inviting me here. As Wade said, I'm Nina Schaefer. I'm one of the senior counselors for the Secretary. In that role, I handle kind of whatever presidential or secretary level priorities might fall on my plate on any given day. I received the opioid file on kind of the first day that I arrived on the job, and have been handling it ever since. Prior to coming to HHS, I spent about over 10 years at the Heritage Foundation, which is a think tank in Washington, D.C., where I ran our health policy and some welfare policy for the foundation. And prior to that, I spent about 10 years on Capitol Hill working for various members, pretty much in the healthcare role. So opioids is new to me. My job in that capacity is really, as everyone's doing their day job, to make sure that something like a presidential or a secretary priority that we continue to move the ball forward every day that we're there. If you've heard the Secretary speak or heard him talk about his priorities, he really does have a sense of urgency, and I think this issue in particular lends itself to making sure that every day we're doing something to keep this moving. The crisis is ever changing, and we need to be kind of ahead of the curve, even though I think we're already a little bit behind on it.
Okay, thank you.
Thanks.
Dr. Rucker.
Hello, good morning. Don Rucker. I'm the head of the Office of the National Coordinator for Healthcare Information Technology. That's a long name. It's a little weird to be the national coordinator. I think I might be the only national coordinator in Washington, I'm not sure. So ONC, as we call it, is really about information and getting information, sharing information, collecting information, and has been working for the last 10 years on electronic medical records. I joined because that's sort of been my personal journey. After doing a residency, I realized I had sort of visions of decision trees dancing in my head. As a medical student, I was a medical student with a great person named John Eisenberg, the late John Eisenberg, whom many of you may know from ARC. And so John filled up my brain with this. When I got to residency, I realized the other thing that was needed was actually data. And so getting electronic data in 1981 was not really something that was happening. I remember writing a letter, a handwritten letter, to the chair of our medicine department asking for the microbiology results to be alphabetized, which at that point was a proven technology. So a ways away from computers, but over the years I've been involved in computer science. Harold Lehman, one of my classmates from Stanford, is here in the back there. And so have been involved with electronic medical records for 30-odd years, and find myself in a unique position of having been regulated by the agency for many years and now running it. Our priorities very, very shortly are to increase usability. We have a lot of EMRs out there. We obviously haven't really cracked the usability nut in a way that clinicians can be happy and efficient, and we have not fully cracked the interoperability nut. A lot of progress being made in those areas, but a lot of work to be done.
Thank you. Bruce.
Good morning. It's nice to be here today. I was involved with Stewards of Change about 10 years ago with Dan Stein in a previous job, and it's a pleasure to see the actual progress that's happened since then to now. And so, because it's been successful, you morph into more challenging problems as you go along, as we'll talk about today. I'm a month on the job as the, just wait, so you know, it's the Chief Technology Officer for HHS. I'll give you a card as soon as I get one. And I come here to do a couple of things. The priorities for this position at HHS has changed a bit over time. If people know Todd Park, that started out about 8 years ago doing this, and Brian Sivak, that is actually from Maryland, that followed him afterwards, there's been a morphing, but mainly it's around the utilization or the liberation of big data within HHS. And so that movement is going on, but we need to take the next step. It's time for 2.0 or 3.0 around the use of data and how we create value with it. It's not enough just to make data available or provide a URL so researchers can look at data if it's not very usable. And so today we're here to talk about interoperability, which to a great degree is what the Chief Technology Officer is to do within HHS. And I like to remind people within HHS and the team and the research community and the community that wants to get to the data is don't just ask or whine about the state of our data or the inconclusiveness of putting data together, but rather lead with what you want to do with it. What is the business problem that you will address with the data? How are you going to change programs to improve people's lives or health outcomes or the efficiency of programs? So that's how we're starting to do it within HHS right now. And I'm interested to get feedback today from this crowd about how you would use the data. Help us figure out how to specify, how to write new business requirements within HHS, how we mandate open APIs and make it easier from the beginning of creating data, not just retrofitting data that's not very usable from the past. And I come to this job from a varied background. Some of the people here today, I just seem to just keep showing up again and again in Washington, D.C. I just came from the startup world where we were integrating behavioral health with primary care. using information, creating an interoperable platform, and really improving people's lives and saving money downstream. I've worked in the large commercial space with Microsoft, and that's how I came across Stewards of Change. I've been a health secretary for a state and running the Medicaid, public health, and other programs, and I've been federal service before running programs, managed care, and demonstration and waivers at CMS. So I've kind of gotten the full scope of view, and I know what the pain points are, and this will be, over the next several years, an opportunity to really address them from a user's point of view.
And I will say that I stumbled on his title because within HHS we refer to him as the grand poobah of technology. But I figured that was not the appropriate title. I should introduce him. Go ahead, Chris.
Good morning. I'm Chris Traver with the Administration for Children and Families. Thank you very much for the invitation to participate on this wonderful panel. I am extremely passionate about this issue. My career is about interoperability. I think I'm the second person in the room that has interoperability in their title. I saw one other person yesterday. So this is my full-time job. It's a very exciting time in ACF to be working on these issues. We've recently created a new division called the Division of Data Improvement, which is focused like a laser on interoperability and data sharing. So we're in the process of standing that division up and really starting to make progress. But clearly we're building on a long legacy of work in this space, both on the part of ACF and the part of Stewards of Change and all of you that are here today. I started my career in software development, and I learned very quickly that the challenge is not trying to figure out how you actually write the code. The challenge is how you understand the business needs of the customer. And so I quickly became something of a specialist in translating business requirements to technical requirements, and that skill was quickly identified by my first boss in the federal government, part of the Department of Justice. So I've been part of the federal system for about 12 years now, but I still feel like the new kid on the block in human services. I've only been at ACF for about a year and a half. So I'm still learning a lot about the field, but hope to bring a lot to the table in terms of interoperability and technology. So thank you for having me.
Great. Thank you very much. So let's get down to it. So one of the major use cases that this symposium has been focusing on when it comes to the application of interoperability is the opioid crisis. I know, Nina, this is something you've been working on with the Secretary for the last 3-4 months, and one of the leads in the department on this issue. Maybe we can start by talking a little bit about the department's efforts to address the opioid crisis, kind of broadly.
Sure. Well, when the Secretary first took his position, he laid out 3 clinical priorities for HHS, which included severe mental illness, childhood obesity, and the opioid crisis. So that really kind of set the stage for us about what we needed to do. One of the great things about the opioid issue, and I think it was raised here, is it really does bring a lot of people together from across all of HHS, but a lot of other places as well. The Secretary really wanted to make sure we were integrating all of HHS so that we didn't have silos working on little pieces here and there, but that we had a really comprehensive strategy for how HHS could contribute to this. And so he laid out a 5-point kind of plan for an HHS-wide strategy that we think really encompasses each agency within HHS. The first one is focused on expanding access to treatment and recovery services. As some people have pointed out, if you don't get people into treatment, we're going to continue to have a problem of opioid abuse. We've got to get people off the opioids and into some sort of a treatment system, and that's with treatment and counseling recovery. The second area is focused on overdose reversing drugs. We see that a lot, including right here in Maryland. You hear the governor has called I think, public health state of emergency and the number of deaths. So making sure not only that we're able to engage on providing overdose reversing technology, but also making sure then when we link it to treatment, because that's at a really important intersection for people, that when they've come out of an overdose, how do we get them into treatment? The third area I think is very kind of focused for this discussion, although a lot of areas, is on public health surveillance and getting data as soon as possible so that it can be utilized in the most effective way. This is one thing the Secretary continues to raise. When you show him a map and it says 2014, he says we are behind. This information isn't allowing us to provide whatever tools we can at the federal level, whether it's grant funding or policy best practices, when we're already behind 3 to 5 years in the data. So he's very focused like a laser on how do we improve getting real-time data so we can make better informed decisions. The fourth area is on kind of cutting-edge research, and this covers a variety of things, not just in drug development where you think FDA, but also NIH and understanding what this addiction is about, and trying to think of what are their alternatives perhaps to opioids, non-opioid drugs that could be used, or what kind of care that people could get that could kind of diffuse the demand for what we've got. And then the last one is on pain management and prevention, and this too, kind of looking at what are we doing as a society, how are physicians engaging in the practice of medicine. CDC put some guidelines out last year looking at how to be kind of smart prescribers, and that has taken off a lot in the medical field. But we really want to look at too, what are some other approaches that physicians can take and folks can take to think about how better to handle pain management, because we do know pain is an issue, and many of those on the acute side leads to then the use of opioids, and then we begin to have a snowball effect in some instances. So he's laid out those 5 strategies. We think we've been meeting internally since we've come on with each of the divisions, talking about what piece do you see that you can contribute to this kind of approach. So you have the obvious, CMS, FDA, NIH, but we're also reaching out to ACF, to CTO, to ONC, to a lot of the other agencies to say, IHS, Indian Health Services, where do you see that this agency can help contribute to this strategy? Because we all know that it touches a very number of lives and it's just not in a silo. So we're working very hard to make sure that that strategy is implemented across HHS. And I think that that will be a good stepping stone for us as we begin to kind of not only lay out the strategy, but then begin to evaluate how we're doing, whether it's in the first year or in 4 years from now. The Secretary has been very eager to say that one of the reasons why he chose this clinical strategy is, and actually all 3 of them, is not because they're easy to solve, and actually he'll point out that it's because these are actually areas where we are not, then the curve is going actually in the wrong direction, and we are behind the curve on this. And so it's a huge challenge and a huge goal for us to make a difference, but we hope that by pulling all the resources we have together across the agency, we can make a difference as quickly as possible.
Thank you. So Dr. Rucker, turning to you. So first of all, I hope that the regulators were nice to you when you were being regulated by them.
At times.
So so you're now head of the Office of the National Coordinator. The theme of this symposium for many, many years has been interoperability, standards coordination, and so forth. What vision are you bringing to ONC when it comes to the broad issue of interoperability, standards, coordination, and the like? What's the vision that you're bringing to the agency?
Well, interoperability, as everyone knows, is an extraordinary challenge, and I think when you look at this, you really have to look at this in multiple different stacks, right? There are the just technical sort of wire-to-wire type of issues with interoperability. There are what are called semantic issues. So if the term I'm using is not the same as the term you're using, then we have a much harder time computing on it. Then there are big business issues with this. Information, as folks in this room know more than anybody else, is economically extremely valuable. And so there are a number of companies in healthcare that are running multi-billion-dollar businesses reselling information. And so there's a lot of proprietary interest out there. And then I think there's sort of the broader cultural issues, some of which goes into permissions. So ONC has done a lot of stuff here in the past, some of it in really each of these areas, starting with some of the technical standards, support for LOINC. We're doing some funding for the new fire standard, have worked with HL7, so a number of the standards over time. An area we can talk about potentially are some of the standards around opiate prescription drug monitoring programs, which are now in essentially every state, 49 out of 50. A lot of interoperability there. If you look forward, it's really the real goal is doing some of the detail work to go to the next steps and to try to liberate the big clinical data stores that are really pretty hard to access now and are often shared. A lot of this is shared with 200-page faxes that comes across, and of course this is an IT nightmare because then the laser printer's out of paper, and as far as people are concerned, it doesn't work. So this becomes very mundane. The three big priorities the three big sort of directional areas were laid out in the 21st Century Cures Act last December. And just to list those, the first is just supporting interoperability wherever it can be done. The second is a more prescriptive thing, which are regulations and penalties on information blocking. One man's technical issue is another man's information blocking, so the regulatory language there is going to be very interesting. I get all kinds of lobbying, even in my month and a half or 2 months here, on what information blocking is and isn't. And the third, which is really interesting, is a legislative demand that electronic medical records have open APIs, so application programming interfaces. So if you look at those things, I would encourage each of you to think of three broad use cases when you think of interoperability. The first, and there are many others, but just the first is really sort of at the patient level. And this can be something like, do I know whether somebody's dependent on opiates? Just what's their medical record? Have they been hospitalized? So patient level data, interoperability use case one. The second interoperability use case is around social accountability of the healthcare delivery system. We spend an immense amount of money. Probably everybody here has done a talk showing the growth in healthcare cost slide. And it's very hard for third parties, whether they're private sector, the Optums of the world, the seemingly dozens of artificial intelligence startups looking at patterns of care, or even federal agencies to get data. So bulk interoperability to get data out to actually see what we as a country are getting and paying for in care. And the third use case, which I think is very interesting as somebody who's spent a lot of time in the startup world, is with the open APIs, can we come up with new business models? I mean, our daily lives have been changed by, Google and Amazon and Uber and, all the travel sites. I mean, yesterday, one airline just canceled my flight, and I was literally on my phone within 1 minute able to book one of the remaining 3 seats out of Nashville last night. Smartphone technology. Could you even imagine have done that 20 years ago with a travel agent after hours? So how can we get that innovation into healthcare so that sort of new business models, open APIs, and of course this is also for all the social programs, is the third case of interoperability. So Wade, that's basically the landscape that I see.
Thank you. So Bruce, turning to you, you come to the Chief Technology Officer position with a really interesting background because you were the Secretary of the Louisiana Department of Health. So you know technology, obviously, you've worked in the field, but you also know health. So can you help us bring these two together? what it is that the department's trying to accomplish when it comes to the opioid crisis, and interoperability and standards coordination and so forth. Bring those together for us and give us some thoughts about how we can use interoperability, standards coordination and so forth, and data sharing to address the opioid crisis.
It's a big question, and what I would remind myself, which I do every day, and all of us here, don't take your eye off the ball. Remember, this is one of the worst health crises we've seen in a very long time. This weekend I read an article that in its background said that overdoses on opioids now is the leading cause of death for adults under 50. The leading cause of death. This morning it was I think it was a WBUR program that's coming on later today, but in its advertisement on public radio for it, it talked about last year the number of opioid overdose deaths exceeded all the Americans that were killed in Vietnam. These are just striking figures. And people that are dying are dying in large cities, small communities, affluent suburbs. There's not one place that it's happening that we can just focus resources and call it good. This is something that doesn't discriminate against income or place. And the probably most innovative solutions that we're seeing, which there's no single best practice and there's no secret solution for this, but they're happening at the local level. And what we're seeing is the discovery of pockets of data and collaboration between social services and treatment and law enforcement coming together, and sometimes unusual and unlikely alliances. And no one's waiting for the federal government to come out with a new data standard or to come out with a new regulation to require interoperability on some kind of federal data set. But we are very eager to figure out what data that we have and how the standards that we control can be put into use to help people that are on the front lines to actually make a difference and save lives. So I think about it every day. I don't know nearly enough to figure out how to promulgate the next set of rules on the technology side or on the policy side to solve a problem that continues to morph in front of us, behavior patterns that we haven't seen before and continue to change. So engagement at the local level and understanding, again, the use case and the need. What is the business problem we're trying to solve? And maybe for the first time, we're talking about bringing together public health, social services, mental health data, along with law enforcement data and treatment data to provide better insights on how far upstream we can go to try to impact people's lives, to apply prevention, to disrupt from the law enforcement side, to disrupt the supply chain that infiltrates places, again, whether it's small communities, rural, urban, to stop the availability of whether it's legal or illegal drugs. So we're learning as we go along. The most important piece is that our boss, the secretary, has a laser focus on addressing this and doing something. And there's a vigorous set of activities that have our sites trained on where it is that we want to go. Without engagement from the local level, state level, county, city, law enforcement, we're not going to get there. So this is a great opportunity, at least for me, to begin a dialogue with the broader community, and we're doing it within HHS across multiple agencies and within states as well. But I'm interested to learn more and be able to put, by the end of maybe this summer, begin putting data out that we have under our control, using our own interoperability efforts to communities and organizations that want to use it to impact saving people's lives and improving people's lives.
Thank you. I think I heard an invitation to provide input into the Office of the Chief Technology Officer around these issues. Chris, let's turn to you and let's broaden the lens out a little bit. So applying interoperability and data sharing to opioid crisis is one use case, but there's obviously many, many others. Two other central big priorities for the Secretary are serious mental illness and childhood obesity. So when you think about interoperability and data sharing, how do you see that also applying to other kinds of use cases and situations where interoperability and data sharing might be able to be brought to bear in order to solve some other very challenging human conditions?
Sure. So I think a lot of the ways that we would apply technology to address these issues are similar across these issues. I think ultimately it comes down to the assumption that if we put the right information in the hands of the right people at the right time, they'll be in a position to make the best decisions regarding the care and treatment of that individual. So everything that we do is about how you actually get the information there that they need. So that comes down to the cliche that we always refer to of connecting the dots. There are pieces of information on these individuals and these families that exist across a multiple of systems, across a multiple of programs, and the question is, how do we bring them together at the moment that they're needed? This is a cross-disciplinary, multidisciplinary problem. It is a human services problem, it is a health problem, it is a justice problem, it is an education problem, et cetera. So at some point, some way, all these communities need to come together to share the information that's needed to make these decisions. So connecting the dots is a complicated endeavor, but it is something that's incredibly important. I do want to highlight the prescription drug monitoring programs that were mentioned earlier. I think are a great example of this because they do serve a multidisciplinary purpose. The primary purpose is to serve the physicians that are issuing the prescriptions so that they can query the system and understand the full prescription history of the people that they're treating. But it was very quickly realized that that data has a variety of uses beyond that. Law enforcement is a major user of the data in a lot of states. A lot of the regulatory agencies make use of the data. And a lot of the functionality that was not envisioned in the beginning of the PDMPs is now being expanded upon, such as unsolicited reports. So we're proactively using the data to provide feedback to the key decision makers to help address these issues. A lot of these issues, we know what the risk factors are. I don't know what they are. You know what they are. We know where intervention is needed. So it's a question of what information do we need in order to bring together to assess those risk factors, and what are the key intervention points where those decisions occur, and how do we marry them together? That's a critical challenge. It's incredibly complex, but that is what I think of when I think of interoperability. How do we bring all these systems together to support the needs of the program, the needs of the decision maker?
Thank you. So one of the key topics and goals of this symposium this year is the launching of the National Interoperability Collaborative, or NIC, which I don't know if there's a representative from the Kresge Foundation here, but they're at a board meeting? Okay, so I'll praise them in absentia for being so forward-thinking and providing a grant to establish this collaborative, which, as I understand it, is really trying to counteract the sort of fragmented nature of many of our interoperability efforts over the last decade or so. And to establish kind of a network of networks, something we talked about, I think, in the symposium last year, that includes public, private, and nonprofit sectors. Given that, and I know that you're not steeped in the NIC, but you understand at least the goals of what the NIC is trying to accomplish, how do you see the NIC supporting, interacting, aligning with the administration's work in this area? And I'll just throw this out to anybody who'd like to address that.
I think it'll be quite helpful. So within HHS, part of what the big data movement for us will be is surfacing multiple data sets, tying them together, and making them available for researchers and those that are actively involved in the running of programs and helping people, whether it's on the public health side and social services and the healthcare side. And so within HHS, we have to emulate something, some set of activities that are very similar. And there's got to be a reason, again, a month on the job and trying to understand why, with people that run the variety of programs, we're in the same building, why have we not married these data together? Recently, the Secretary has assembled really organically across the whole department people to come up with new ideas. The effort's called Reimagine HHS. And the input from employees, 79,000 employees from around the country and around the department, solicited sets of recommendations and initiatives. Nearly 40% of those recommendations included either technology modernization or some way of making the data that we have more useful. And in the data recommendations, almost all were bringing the data together so we can use it in a more value-added, more effective way. But again, there's a reason why it's not being done. It's not that there's some people that just think it's a bad idea or say, well, no, it's my data, you can't have it. There are multiple obstacles. And so we're happy to take a lesson from the game plan from the foundation, or we're happy to collaborate and have some others from the outside help us on the inside, bring the data together, because we want to produce something that's usable for the rest of the country. It shouldn't be an artifice that we put up on a website or on somebody's bookshelf and never gets used. It's got to be adding value to those that are going to use the data, again, to improve people's lives or the efficiency of a program. So we are beginning to very actively pursue this, and you'll start to see some things coming out of the office over the next probably 3 or 4 months. As we convene groups, we look for input, we look for use cases so we know how to build our data set and make it available. And of course, this is part of the open data movement. There's some discussion internally. I have to come up with a better name. I'd also like to crowdsource a better name, but there's a closed data movement. And by that, we have identifiable data with personal health information involved that, if combined between healthcare and prescription drug, social services, and public health information, you think about the variety of agencies within our department, researchers from the inside, without having to abridge privacy, would be able to engage in some research that could lead to some interesting discovery that we're not able to do now because of privacy issues. And whenever we make data available, it'll be anonymized, and some of the important factors must be eliminated. So that's what we're thinking internally, to be able to interrogate this data in the most useful way possible. And then for the external, for the open data, we want really the best use cases so we can envision how it will be used the best way for those that need it.
That's interesting. So you mentioned the HHS Reimagine initiative, which I'm not sure how many people here have heard is going on within HHS. There's someone here from ACF who was actually on one of those discussion groups. And it was interesting that about 40% of all of the recommendations really focused on this. That surprised me, but I thought there might be a few data geeks that would think about that, but it surprised me that it came up again and again and again, no matter which sort of group they were asked to focus on various topics. Dr. Rucker, I imagine that the Office of the National Coordinator will have something to say about this as we start to move towards implementation. So what are some of your thoughts about how we might translate those aspirational goals into something that is achievable within HHS?
Yes. Well, the 21st Century Cures Act actually requires us to do it, so it's not really volitional. I think having stakeholder engagements really helps in providing some of the broader social and business context here. So I think the work that you're doing here and the Kresge Foundation is doing is very helpful in setting that up. This is a work in progress. All right, so let me just throw out some of the challenges. For example, there are a number of regional and statewide health information exchanges, HIEs is the term. And then there are some vendor exchanges, and the vendor exchanges sometimes focus on maybe one vendor. And so how do you disentangle that? How do you get information sharing over multiple providers with multiple vendors is a very big issue. Part of the challenge here is that this also wraps up into the whole affordability of healthcare. So one of the other issues that we're sort of trying to understand is how do we get market competition back into healthcare? And if you look throughout the United States, increasingly there are very large concentrated providers of healthcare. Probably some of the people in the room here have studied and shown some of the cost hikes that come when you have these type of market consolidations. This has been an active area of research. Information is the absolute heart of those types of anti-competitive behaviors. So, we're going to be looking to see how we can actually lower transaction costs throughout the system so that people can actually shop for more affordable health care. Many of us are in high deductible health plans, and so looking at massive deductibles and are being incented from legislatively to actually shop, which in American healthcare has not happened since 1965. So information is at the heart of that. So I think one of the things that ONC is trying to do is look at information sharing from an economic competition point of view as well.
Thank you. And Chris, so you're the old-timer federal leader here on this panel. So I'm going to ask you this question. So again, interoperability is something that people have been talking about for a while. I think it's really good news, certainly to me, and people care about interoperability. There's such a focus on it with the new administration. As someone who's been inside government for, just a short amount of time in ACF, but longer within the federal government, what are some of the barriers internally that make it difficult for the government to move this agenda forward? What are the obstacles that you've encountered, and maybe some thoughts on how we can overcome those?
I'd say there are many. What comes to mind first is clarity of purpose. What is our objective? I hear the word interoperability pouring from the lips of so many people. It blows my mind every time I hear it. But when you ask the follow-up question of, well, what do you mean by that? And what do you want to accomplish? It becomes a little bit more of a complicated discussion. So I think understanding what we're trying to achieve through interoperability is really key. I think it's the kind of thing everybody wants, but nobody's quite sure how to get there. We have challenges internally, just as there are challenges across the states and on an interstate national basis with our interoperability of our own systems. We have very segmented funding streams, segmented technologies, the way that our different program offices invest in their own systems. There are numerous challenges that contribute to the distributed nature of the technology investments that we've made. So in a lot of cases, we're having to go back and sort of add connectivity where it wasn't built in from the beginning. And this is not a problem of vision. This is not a problem that somebody forgot to include something in an RFP. This is an evolutionary process. So we're getting better and better at sharing information and ensuring that our systems can communicate. But it is a significant learning process. Most of our staff that work in the program offices do not have technology backgrounds. So where does that expertise come from? I'm hoping that that's one of the things that our Division of Data Improvement can really help with, is be consultants internally and support them in these sorts of activities. We do have that expertise, but we have a small but dedicated staff that can hopefully make some impacts. But those are some of the organizational challenges. I won't get into the more technical challenges, but certainly the semantic interoperability of the data, the standardization around and alignment of architectural frameworks. These are all things that we're working on that hopefully will be able to expand adoption to increase the consistency of how our systems are built to be able to communicate. I'll leave it at that unless you want to get in more detail later.
Dr. Rucker, it looks like you've got something to add.
Yeah, one interesting observation on interoperability that I would throw out is that often there's a very fundamental confusion between interoperability and the business cases for formulating the data. And let me give you an example. So in healthcare right now, broad strokes, there are some types of data that are exchanged pretty readily in some broad swath. So machine-generated data, imaging data, pretty much any imaging vendor, any CT, any MRI, plain film, all of that goes into any vendor packs quite smoothly. Similar for lab. But then you get to problem lists. So what are the patient's problems? And there, you know, interoperability sort of goes away a lot. And I think it goes away is because people have not realized that there are two things that are in that ask. One is interoperability, but the harder one is actually for somebody to organize and collate the data before it quote unquote interoperates. And I know that's not a word, but and so we have to be very careful that what we're asking is possible that somebody already has some organization of the data, and often it's the organization of the data before you share it at all that is the true economic cost here. And how you do that is often a very big issue that I think is systematically confused in the discussion of interoperability. So before you want to get it or send it, just ask yourself, who's going to pay to organize it?
So Nina, I know that you're not a deep technology person, but I know that you've been involved in discussions within HHS with the Secretary, and where the Secretary would like to reduce some of the burdens that the federal government has exercised on or imposed on the doctor-patient relationship. And one of the interesting things is that we've heard is that the push towards electronic health records has had an unintended consequence, which is that doctors are now spending more time looking at the screen than looking at the patient. Can you talk a little bit broadly about some of the work that's being done within HHS around reducing burden, and then maybe focus a little bit, if you could, on this whole idea of, you know, that we also need to be aware of unintended consequences of some of the things we try to accomplish. And maybe someone else can add, did we rush too quickly into electronic health records? Because I know it is true. When I just had my annual physical, and I'm a wreck. But the doctors spend more time doing this than listening to my heart and so forth. So anyway, if you could talk a little bit about some of the efforts that are happening around reducing burden of the federal government, and maybe you or others could have some ideas around electronic health records.
Sure. There's certainly a regulatory reform initiative that's kind of taking across all the federal government, and HHS obviously is one of those key agencies that has a part in it. And you're right, the Secretary has identified various areas, just as a whole, over the agency-wide, what are regulatory reforms that could be done. In those efforts, you realize you have regulations that have been on the books for decades that really have no practical impact on what people are doing today, or are really outdated, but clog up the system. And then on the other side, when you mentioned the doctor-patient relationship, one of the tasks he gave us is to say, does this hurt the patient or does this help the patient? And it's not even really about the physician himself, although he's a physician and probably says, anything that makes me go on a computer, takes time away from a patient. But it really is getting at how do we improve that doctor-patient relationship, and how do we make sure that as rules and regulations are coming in, that it's being seen by the lens of the end user, which is the patient themselves. And so it's a large undertaking, and you would be surprised how similar on the opioids, where it's not just, you'd say, again, it's just in CMS. It's not. It's everywhere throughout the agency. So really trying to turn over each of those stones and to really look at it and say, is this getting in my way or is it not? So that's probably a long undertaking. Probably will take us the entire time that we're there, and probably still would leave some that are in place. So I would leave with that. On the whether there are unintended consequences, I think about that as well. We're in a rush even now with the opioid crisis. What can we do? How can we release the information? What do people need immediately? And echoing something that Bruce said earlier, I think we've traveled with the Secretary to many of the states that have been horribly affected and will continue to be traveling. And something that has come so true, that it's almost easier at the local level to overcome those barriers and those challenges. And that it's very heartening. You feel great that these are neighbors helping neighbors, figuring out solutions. We went to one place, a fire department, where it was actually had a program, and I think someone said, well, who came up with this idea? And the fire chief pointed to one of the firemen and said it was him. He had a neighbor that had come in, wanted some counseling, didn't know where to go, what to do. And it just spurred the effort to say, well, let's get this replicated across the whole city, and how quickly can we do this? And they got it up and running within weeks. If that came from a federal grant, it'd probably take 2 years before we would even begin to see any sort of impact of what's going on. So really looking even at how we fund a lot of the programs, making sure that we're getting the biggest bang buck that we can get, without creating unintended barriers or requirements that will kind of slow the pace of it. Because again, this is not a crisis that we can wait 5, 10 years to solve. We really need to start making some sort of a dent in it right now.
Do you have some thoughts on electronic health records?
Yeah, I have lots of thoughts on electronic health records. We'll start. I was involved in building the first one under Windows, so I'll give you some advice. Never try to program anything in Windows 2.1. It's not stable. Well, we've come obviously a long ways, maybe. But I think part of the challenge that ONC and HHS have is the law of unintended consequences has hit pretty hard in this electronic data and in this electronic health record, and it's a very dense mix of issues to untease. They come from things like cognitive science, and the fact that the clinicians who all tell you, oh yeah, I know how to design an EMR, actually think they're logic machines rather than pattern recognizers. So you have some fundamental things. It comes from the programmers who were all taught to reuse code libraries for user interfaces, even though those libraries were built for desk users and had nothing to do with the dynamic interoperability nature of a clinician who's interrupted 60 times an hour in almost every clinical setting around or more. And so we have these technical things, and then frankly on the policy side, we have, as the folks who are clinicians here know, immense documentation requirements in our evaluation management CPT codes that have made most modern American medical charts just bloated beyond belief. There's some interesting data from one of the large vendors. American EMR records have 4 times as many characters as this vendor's foreign customers, rest of world, just as a measure of inefficiency through our stack of essentially government policies, which is the real delta. Americans are not healthier than or sicker than folks in the rest of the world. And so we have these funny things. We're adding, of course, new things on quality measures. Sounds pretty good when you start. I've been involved in ONC and CMS. We're trying to do a lot of reform stuff. And we're digging into the incredible costs of generating quality measure data that at the end of the day has very, very small marginal benefit and probably potentially significantly more costly than the benefits. Again, that has not been well researched, but there's some interesting things here. So I think the net of it is, as we look at usability and interoperability, there's a lot of detective work that needs to be done to untease these threads, and then, as Nina was saying, figure out which of these are the place where we want to try to bring some solutions. It's a daunting and a very interesting problem, and we've all created it for ourselves over the last 25 or 30 years. Pretty much everybody in the room here may have some component of guilt. I know I've been involved.
So we have just a few more minutes before Secretary Hazel will provide some sort of observations based upon the discussion with the federal leaders. So I want to end with this question. So you're at the beginning. 4 years from now, how will the world be different if what you want to accomplish gets accomplished? What will the world look like 4 years from now if the things, the aspirations that you bring to your positions are realized? Nina?
Well, it keeps me up at night sometimes, coming to the public sector and devoting an agenda really of trying to achieve what the Secretary has laid out as his agenda for his term. I would probably say, because I focus, some days I try to say 75 to 80% of my day just keeping the ball rolling on opioids, that we have a better handle on what's going out there, and that the tools and the best practices, I think, is one of the most important things the federal government can do, which is to help be a megaphone and to share the information at the state and local level. So making sure that the federal government is doing its part to provide that information, whether it's data or best practices on things, and that it's making a difference on the ground.
Dr. Rucker.
I think 4 years from now, if we can do some of the work on cleaning up electronic medical records so they're more useful for patients and physicians and all providers, and lower the costs of healthcare by doing that, right? Because somebody pays for that. When the doctor's typing at the computer, that's not free, right? We all pay for that in our health insurance premiums. And then I think the other thing is that we have enough interoperability that some new business models have started, and we've injected some competition into the health marketplace using the power of modern computer science, which has been stunning in every other sector of the economy.
Bruce.
This is a profound question. It's a pretty big one. So basically, you're asking, is what you're going to do in your current job going to mean much at the end of 4 years? And it's an existential question. So, the funny thing is that we all, I don't see a lot of teenagers here. We've all been doing what we do for quite a long time. And so maybe just look back 4 years behind and see, where have we gone in the last 4 years? Are we going to draw a straight line and call that good? Or is this the opportunity to do some things that we've been putting off or not able to get to? So I'm thinking quickly to answer your question. So I think that on opioids, if we can give better tools to people and communities to address and reduce the harm that's in overdose, deaths, and people's incredibly disrupted lives, to help overcome some of that pain and burden and death in the opioid crisis, it'll be an incredible accomplishment. I think about the other constituencies for HHS, and what we're talking about is interoperability and overall technology and reducing burden, but what does that really mean? So when I think about it, what if for those that are applying for grants as researchers at NIH and CDC, what if I can cut the burden of applying for a grant and providing very time-consuming quarterly reports that maybe don't add much value at all, like some obscure quality measure that makes the bureaucrat feel good, but for those that are producing it, the researchers and the physicians and their subjects, it's really quite painful. If we can reduce that by half and then give back the researchers more time for discovery. What if on the state level, those who are running programs under federal authority, what if the idea of giving the states more flexibility, and this is not just pie in the sky, this is something that we're likely to see within the next year across a variety of programs. What if we can make the data and information available, the kind that they need to run their programs much better, so they can provide better quality programs, higher and better outcomes in wellness and well-being and in health outcomes at a lower cost? less duplication of effort on the programmatic side, and lower expenditures, especially around duplication, on the technology side. Those are the things that I think about that are within grasp, that we have to do, or else we'll have failed for the next 4 years. And all y'all need to hold us accountable every day. And every day that goes by is one less day that we have to fulfill these missions. And so I feel like we're at a frenetic pace, and it ought not stop the whole time that we're blessed to have our jobs. And so expect to see a lot of action coming out of HHS.
Nina keeps asking at HHS, is it ever going to slow down?
No.
I lie and say yes. Chris, how about you?
Sure, I agree this is a great question. I'm tempted to give a very boring answer, like I want to see increased adoption of the National Information Exchange model and those kinds of technical tools, but I won't do that. I'll instead make the case that I think we need to see a cultural shift, and I have identified 3 avenues through which hopefully that will start to occur. The first is a transition away from data ownership to data stewardship. I think if we consider ourselves the stewards of the data, the information on the people that we serve, as opposed to our program's data, we might make different decisions with respect to how we manage and share that information. I would love to see a move towards a data sharing first mentality. I think today the mentality is not to share unless, and I would love to see us move to a share unless a reasonable rationale can be provided to the contrary. And lastly, I would love to see us be more practitioner-driven and not program-driven. So rather than build our systems to meet our program needs, consider how the end user interacts with the system, how our clients are interacting with our systems, and how well that relationship is working for them. And the program stuff will come along in response to that. So hopefully some of that we can make some progress.
Terrific, thank you. So I hope you are as impressed with this group of new and longer term leaders on this issue at HHS. And I invite you to join me in thanking them for coming here this morning and participating. And now we'll invite Secretary Hazel to come up and give his remarks.
I think I can just handle this from here, Wade.
Okay,
but
great.
Thank you. This is a great discussion, and I'm encouraged by it. I've just asked to offer some responses, and as usual, I make it up as I go along. But first, since Nina, you don't know me, I'm also a recovering orthopedic surgeon. I went into recovery when I came to state government with Governor McDonnell in 2010, and HHS is like this. It just doesn't, and it changes constantly. So, welcome to the team. The couple of thoughts. First of all, it's interesting when we started off on the questions, we tend to dive into the technology. And it is the cool stuff and the whiz-bangery and everything, but I see that your challenges are cultural to a large extent, but also significant policy issues. And it's not just healthcare. I think that what we have learned, we learned from our European colleagues and so forth, that the well-being may be more important than the health, if we use the term, and that it is very difficult to quantify. You might be able to qualify it, but unless we are able to reach out of our HHS environments and think about the bigger picture, we don't get as far as we will. And specifically, one of the things we have seen over the last few years that has been good is last year we were able to go to panels where there were people from FNS. Those are from agriculture, HUD, Social Security, all on the same panels to talk about the things that impact people's lives together. And I hope we can continue at least that trajectory of thinking beyond our own, and pardon the term, but we're from Virginia. We have cylinders of excellence, ma'am. We don't have silos in Virginia. So I would say that the political task or the policy task as you reform, that doesn't mean just breaking, it means reforming, is creating the alignment that we need, that because the sum total of our programs, and I think you've pointed out, don't necessarily work, and there are barriers in the programs to getting our people to self-sufficiency. And it's because these programs have come up independently, and I think so the policy is underlying all this. I would encourage you to think about the fact that the underlying technology, the possibilities have changed since the laws were established. And getting Congress to do anything, obviously, is a challenge. But we now have the ability to have better sharing and more security simultaneously, to use rules to see who accesses the information. It would make a lot of sense to try to level set across the agencies in a little better way. If we always hear about CFR 42, you know, is in Chris's world and in child care, if we have a child in foster care, what we need to know is whether the child's going to school, how they're doing in school, things like that. So FERPA becomes an issue. We cannot look in the healthcare silo, in the ACF silo, without thinking about education and public safety and juvenile justice. So I encourage the thinking to be a little bit broader. Clearly, the flexibility around grants and oversight is much appreciated. The time it takes from start to finish, I talk to our folks and I say technology projects for our legislature, it's like second marriage. It's a triumph of hope over experience. And we have, you know, we have the issues because we have to go through the hoops when oftentimes it's just redoing what's been done elsewhere before. So I applaud that effort. I'd ask you to think a bit about how we procure. I think, you know, I've often thought if we could reform hiring and firing and procurement, the rest of government could begin to take care of itself. And so none of this is technology as much as it is thinking about the background for it. Dr. Rucker, I agree with you. As a recovering orthopedic surgeon, we have managed to almost achieve meaningless use. In fact, my colleagues are working more slowly, and it's much more expensive now, and it's changed their practice patterns and the mergers and things that have shaken up just to afford the technology is incredible. And what I worry about, I mean, I'm an absolute believer in exchange, I really do. But what I worry is as we look at our social determinants and our need for our colleagues in public health and social services to interchange with the health record, let's say around opioids. We clearly have to know where people have been because they cross jurisdictions. And we have to have that exchange, but can we figure out a way to do that without making some of the expensive mistakes we've made before? What can we learn as we do, and don't just drive into the medical model, but can we think of better ways to move this information? So that's a challenge that I would have. Nina, for the addiction, I think Bruce hit it. It's the harm reduction first. Absent resources, personnel, and funding, we don't get the treatment. But I would encourage you to think in terms not just of opioids, but in terms of addiction and where it impacts all of us. It's not just the healthcare costs, it's the crime, it's the leading cause of family disruption. And the ability for us to find the families and to use the whiz-bangery that we have to identify the entire pattern around a child or a family is going to be increasingly important. And that's a whole new set of challenges that we don't think about so much on the healthcare side of things, but it's absolutely critical. When our social worker goes to a house, they aren't armed, they aren't the police, and they're going to take a child. How do we know in advance what is there, Bruce? That's the use case, you know, that we really have to be able to solve. I can go down, I'd just ask one more thing I think in follow-up is in terms of your use case, there's things we don't think about. Yes, we think about surveillance and we think about dashboarding and we think about streamlining eligibility and we think about case and care management. We think about research, but to have a value proposition for what we do, we have to know baseline costs. An intervention like medically assisted treatment costs X amount per person per month, but no one can tell us what it costs to do nothing. And I think we really have to find a way to look at the economics across systems at local levels, where the providers are, the state, and we're your partners. We're not your average, you know, I would say vendor, and I know that there's a temptation to treat us as being punitive if we don't get the, quote, results you want, but we're in it economically like you are. And so we need to find ways to look at where these costs are and look at the cost of doing nothing. Thank you.